and welcome to IACD's first Fireside Chat. I'm Roxanne Thompson, and Clinical Director at IACD, and Beverly White is also a very long-time therapist with IACD, and we are going to just chat today about some questions that have been sent in to our website, and we're going to try to get through all of them today, and if we can't get through them today, we will have part two. So let me tell you a little bit about me. I am, as I said, the clinical director at IACD and also a therapist, and had been in practice for about 28 years in the Denver metro area, involved in several boards having to do with foster and adoptive children and families, and has taken me to a different place where, as an extension of my work through the years, is that I am also a musician and have been for my life. And I have combined both of those things in starting a choir of foster and adoptive children and an adult choir as a mentoring program. So I've been able to do several things and love working with this population. Beverly, you want to tell them a little bit about you?
Sure. I'm Bev Baker White. I used to sing, so but I've not been invited into Roxanne's choir. So
anytime, Bev, anytime.
Thanks. You'll be sorry. I am a psychotherapist over 30 years. I think I'm in my 33rd year now. And my private practice is Littleton Family Counseling, but I have been with the Institute for Attachment and Child Development basically since 1988. So I've come and gone because I'm also a school counselor. So I've worked in elementary and secondary schools, and served after that as a liaison for the educators and the parents in building 504s and IEPs and any other help I can provide. I'm an equine assisted psychotherapist, as well as I provide EMDR. And my next venture was brain spotting, but thanks to COVID, we had to cancel the training for brain spotting. And thought field therapy is one of my modalities. So I just really enjoy working with individuals and families and kids. And so I keep working because it's a joy to me to be able to be helpful and help families find some joy for themselves.
Okay, thanks, Bev.
Sure.
So let's get to our very first question. The first one that came in is, are attachment disorders the fault of the parent? Well, that's kind of a loaded question.
It's a yes and a no.
Yeah, that is a yes and a no.
Mm-hmm.
Sometimes it is the parents that have not been able to connect to the child, are neglectful, are inconsistent in their parenting, are abusive, or put the child in abusive situations. The other piece of that people don't think about very much is if there's a child who's born with significant medical problems at birth or very young, and they're in the hospital a lot, or having medical procedures that are painful or scary, and they're away from their attachment figure, which would be the caretaker, the parents. That also can be something that helps form the poor attachment in children.
And there's no way to determine which children are going to have the attachment disorder and which aren't. There's just not a proven way to see that, particularly with the kids who are hospitalized at birth. We also have situations where the mother, the major caregiver, gives birth, but then she's not either emotionally available to the child, and that is an opportunity for the attachment to be at risk. And then there's the situation where if a mother has to go just back to work and another caregiver is taking care of the baby, and then another caregiver and another caregiver and another caregiver, there needs to be consistency of the same caregiver every morning, every evening, every morning, every evening. So if mom works, that's fine. It's just the baby needs to see mom every morning, every evening. Consistency of the caregiver will support the attachment. But it's a two-way street. It's not just the baby attaching to the mom has to attach to the baby. So that's the basics of it.
Yeah, and you were talking, Bev, about the unavailable parent emotionally, and a lot of times that's because there's a parent who has some significant mental health issues of their own, like depression, and
or attachment issues.
Issues.
Let's say they have their own attachment issues, right?
Right.
They don't really know how to bond with a baby.
Right. Or even drug and alcohol issues, which also a person is very emotionally unavailable when they are actively using drugs and alcohol.
Right. Right. So I hope that answers that. It's like you said, it's a loaded question. There are many multiple factors that that interplay with that. So the second one, can trauma occur prenatal? This is the second question. Can trauma occur prenatally? If so, how do parents and therapists address and treat that? So the answer is yes, it can occur prenatally. There is a doctor in Canada by the name of Dr. Verney who wrote a book in the 90s called Secret Life of the Unborn Child, I think is the name of it. And he started studying what happens in utero. So yes, there are, what do I want to say, emotions developing. I think what the mother's experiencing, then the baby's experiencing in utero. And so short answer is yes. There's a long answer to it as far as the research goes, and the studies are ongoing, and we don't know all of the answers to that yet. So Roxanne, did you want to add a little bit to that? Like drug and alcohol prenatally, that affects, that's an effector.
Yes, and I do know, and I've had many kids that I've seen through the years in therapy that there was some domestic violence before the child was born, and the child actually has a sense of fear because the mom was afraid, and a high level of the with that fear response. So the child can actually recall without words, because of course that was pre-verbal at that pre-verbal stage, but they can have a sense of that there's something fearful going on here. And that's part of what the brain holds without knowing time. So yes, that prenatal influence is extremely important. And also a child who the mom has made up her mind to relinquish at birth, that also will impact that child's ability to attach easily.
Yes, yes. And if there's a history of substance abuse while carrying the baby, there's actually no testing for fetal alcohol syndrome, which is now called alcohol-related neurological disorder. I don't know of a scientific test for it, but there are features that clinicians observe or assess to make a determination. So actually now I believe they're saying the first 3 months is the most critical if a mother is still abusing alcohol particularly, because she may not know she's pregnant initially and still keep drinking, and as it's a setup for the baby. So
yeah. Going back to a little bit on that domestic violence in the prenatal stage, my godson was going to be relinquished at birth. The adoptive parents went all the way through the pregnancy with the birth mom, but she had been in a relationship that she was hurt, and her stomach was hit with an object. And when she relinquished the child at birth, the adoptive parents were there at the birth took the baby home from the hospital. She only held that baby probably for a couple of minutes, and they took the baby out, and the only other contact that baby had was with the adoptive parents. So, logic would say to you, well, that baby's not going to be attached or feel any kind of attachment or familiarity even with that birth mom. But that's not true. And so they lived about 90 miles away, and for about 6 months, this mom didn't want anything to do with this baby. It was all done and said. And all of a sudden, she decided that she wanted visits with her baby 6 months later. So by law, because that adoption had not occurred, then the state and the county had to allow this birth mom to have visits with this baby. From the very first visit, when the adoptive parents would hand over this child, he would become so dysregulated. He would cry. He would stiffen up. He was unconsolable. And that would go on through the visit, the 90 miles back to Denver, and for the next 2 or 3 days until they just about get him settled down, and he'd have to go back and do this again. And it got to be so ridiculous for this child to be up and down, and he was a newborn. And he was, 6 months old, not a newborn, but a 6-month-old child, not understanding why he had to be with this person that scared him, that he had a feeling. He couldn't talk yet. And so eventually the county said, okay, we're done. We're going to terminate this. And he has had issues with attachment his entire life.
Yeah.
Now, do we know if that was because of him having to have visits? We don't know. We don't know if it is because there was domestic violence in utero. We don't know. Probably a combination of both.
Mm-hmm. Mm-hmm. Well, and the being taken away from the birth mother is traumatic itself, so that creates its own dysregulation in the brain. And babies do know mom's voice when they come on out. They know if it's the mom's voice or it's not the right voice. They do know that. So that's unfortunate, but I've heard stories similar to that myself for years. And it takes a while for individuals to put the pieces together to know that it's dysregulating the child to continue the pattern. Yeah.
And I would add to this, one thing that I've always, in my trainings and also when I'm talking to parents, is the mom is the first home. It's the first smell, the first touch, the first sight, the first hearing, everything, the first taste even. Okay. So that attachment starts in utero. You are in that home for 9 months. Okay. There's no language attached to that. It's only emotion. It's only feeling. It is absolutely that most primal stage for that child to start that connection. And when that is severed at any stage, there is going to be a problem. And some children are more resilient and can come out of that pretty easily, and some children cannot. And this also kind of stops that attachment process, or if it doesn't stop it, at least it hinders it.
Yeah. Yeah.
Okay, so anything else on that, Bev, that you want to add?
I don't think so. I think, if our listening audience has other further questions about it, I invite them to go ahead and send in the questions, and we can readdress it the next time.
Excuse me. Well, there was a second part to that question of how do parents and therapists address and treat this with the prenatal trauma. And that kind of leads into our next question.
It does. It does.
And our next question is, if a teenager is diagnosed with attachment disorder, Does the child's history, like 0 to 5, need to be known for effective treatment? Okay, there are many times that we don't have that information. We are so lucky if we have that as clinicians, because that gives us a better picture of where that child's coming from and what their process is going to be. It's more predictable for us when we start to work with a child. If we don't know that, we have to go on some assumptions, number one, and we have to just be very tuned in to how that child is responding to parenting, environment, direction, and what their attachment looks like. And we can, if we've been doing this long enough, we have a pretty good idea if something has happened or when things have happened. So we treat attachment issues and again, let's just say, let me add that there is a continuum of the ability for a child to attach. So it could be just very minor attachment issues all the way to a reactive attachment disorder. And Bev and I have worked the continuum for years.
Yes. And it can go into adulthood, and adults can still address it as well in their
absolutely yes
life. They can address the trust and intimacy issues that are problematic with attachment. So yeah, we have to figure out a baseline. So we ask the adoptive parents to give us all the information they can and all of the current behaviors that they're seeing at the time they bring the child in, and whatever historical behaviors they want to give too. So we have to have a thorough view of the behaviors and any triggers. If they can recognize any triggers, trauma triggers that would accelerate the child's anxiety, where it's about developmental trauma, and it's about relationships. So if we can get as much information as we can about those behaviors, as well as the parents' response to the children, it will help us start our treatment plan. So we have to have a baseline, and it is more difficult when you have children, say international adoptees. Sometimes in the Chinese orphanages, there will be a nanny that will have 5 or 7 little children, and she might write, a few sentences about the child. Even that's helpful. Just even a few sentences about that baby is helpful. Or how long they were in the orphanage makes a difference. Which orphanage makes a difference. Whatever information we can get. Some of the kids are left on the orphanage steps in these countries, foreign countries, and so we just don't have the information. We don't even have accurate birth records. So we have to just take a guess at their actual age. We also need treatment. We address it if there's any previous therapy, or any previous psychiatric evaluations. That helps us too. If there are any records from CPS or Department of Human Services, that will help us. We just need a lot of information. But I think it's just important to recognize it as a trauma disorder. And a lot of parents don't have the psychoeducation yet to know that. And so there's a lot involved in the treatment. It's not just the treatment of the child. It's psychoeducation for the parents and giving new parenting strategies to address parenting trauma. Do you have anything else for that?
Yeah. Also, one method that I use as often as I can, honestly, is to help the child understand kind of what has happened to them. Mm-hmm. Younger children are not going to be able to do this as well as a child who's, a tween and up, for like 11, 12 and up. When they start asking questions is kind of my go-to. I'm not going to push that on any child at all. A lot of children know their adoption story. But there's gaps in that, because if you get a child in your home and you've adopted them through the system, there's a little more history But when we have children like Bev was talking about that come from orphanages, we have very little. Okay. So I'm working with a young man right now who's a teenager, who was adopted out of China, out of an orphanage. What we do have, we don't have much information, historical information, except there's a lot of pictures. For some reason, there were a lot of pictures of this boy, and he was 18 months old when he was adopted, and when they went over to pick him up. There are some really amazing pictures of him standing by himself out in a courtyard or looking at this wire fence. And I use that in therapy with him to get to, because he's kind of flat. He doesn't like to give you a lot of emotion. And we've been working on his emotional reporting, just reporting his emotions for a long time now. And he's getting there. But using those pictures has been a real help in his therapy, because he gets to see who he was when he was 1 year old, when he was a year and a half. And I ask him, what does that look like to you? What does that little boy look like to you? And he gets to tune in to who he is. And it's been a really valuable tool for me to be treating kids.
Yeah, the pictures are so helpful. And another tool is to have the kids draw a picture of their family. One of my little girls, I said, okay, draw a picture of your family. She took the entire page, 8.5 by 11, and drew her face. It was just her. She was compulsively self-reliant. I don't need a family. I don't have a family. They brought me here, but it's all about me. And so don't talk to me about family. It's just about me. Mm-hmm. So the pictures they draw also speak volumes. They just speak volumes. So I love when there are photos, to use.
Yeah.
So, yeah. And also whatever they draw. They also say to me, what family do you want me to draw? And you just draw whatever family you want to draw. And then we go from there. The other piece is that because they're on hyper alert and their anxiety is so easily triggered, they haven't learned the words for their feelings or to connect their feelings to the words. So we want to teach them, I know it sounds trite, but mad, sad, happy, and scared to begin with as a baseline for their feelings, because often they'll just say mad or sad. They won't say happy, joyful, scared. Scared's the last emotion that they want to admit to having, although that is typically the root of the issue that's driving the other feelings. So we do teach that early on to help them connect. And it takes many kids a long time to actually connect feelings, to learn what they are, and to be able to say, oh yeah, I felt sad then, but so I love the pictures though. Those are very, very helpful, but we have to start with basics.
When you're using the teaching the feeling words, mm-hmm. This young man I was just talking about, he would not express any feeling words at all. And it has taken us months and months of just working on feeling words with him, journaling. Mm-hmm. And I gave him a large thing that had all this stuff on this page that had all these different feelings. There's probably 75 feelings on there. Yeah. And it blew him away that there were that many feelings. Yeah. Right.
And the pictures, do you have the pictures to go with
them? Yes. And so his assignment was to put that in his journal book so that he can search for words to explain how he feels. And as I talk about that a little bit, we also have to be really careful about what limitations kids have in expressive language. And also children who don't interpret other people's feelings very well.
And the cultural differences too.
Cultural, and also if a child is even mildly on the autism scale,
right,
they're gonna miss stuff. And we have, as therapists, we have to be really, really clear where that child's coming from, and the expectations for being able to express feelings and understand feelings can be compromised in some way as a result of that. So we have to be very clear about that.
Yes, a therapist years ago brought a young man to me to work with, and he said he just won't express himself. He won't say anything. And so I had the child come in, and he stood in the corner and defecated. And I said to the therapist, he's expressing himself. I said, he's just giving us exactly how he feels. So, yeah, he didn't want to talk about it, but he wanted to show us. So,
Sure.
you know.
Thus, actions speak louder than words.
Yes, they do.
Yeah. Yeah. Okay.
Yes, I knew what he was saying. So
Right.
Ready, Roxanne, for our next question?
You betcha. Go for it.
Okay. What information can you give, or resources that you can recommend for reactive attachment disorder children forming healthy relationships versus learning how to manipulate to get what they want? So I like this question a lot. Again, teaching feelings. There's a book called Feelings. It's a kid's book, and there's a kid on the front, and I think it's just called Feelings, and that's a good start. But the resources is, you know, you have to find an appropriate therapist, for one, and I don't know if we listed it on the website or not, but there are tips to how to find an appropriate therapist. I can go through them. Roxanne, should I review those or not review
Yeah,
them?
you can do that. Sure. I think that'd be very helpful for people.
Okay. So resources, find an appropriate therapist. Okay. So you want a therapist who's not into making friendship with the child, because the child will then want to lead the therapy. So you need a therapist who can be highly directive. And the therapy must involve the parents, because attachment's a two-way street. So you have to have the bonding caregivers in the therapy. You want a therapist who knows as much about the child's history as you can provide, including previous therapies and medications. You want to know if the therapist will assess if and when a psychiatric evaluation may be in order. Is the therapist trauma informed? Will the therapist provide a safe, structured environment in which all, including the parents, all feelings are sensitively addressed, and teach affect regulation within the context of caring boundaries? So you do want someone who's familiar with developmental trauma and attachment disorder. The words are not necessarily interchangeable, but attachment disorder has a developmental trauma base. So I think that there are books to help you, give you an idea of what to look for. A Secure Base, written by Bowlby, is an old book, but it's really books by Mary Ainsworth. The Old Basics of Attachment Disorder, The Breaking of Bonds. There are a lot of books. I do have a bibliography, and we don't have that posted on the website, but there are newer books and older books. So the older books are like A Secure Base, The Secret Life of the Unborn Child, which I mentioned before.
Primal Wound.
Patterns of Attachment, Love is Not Enough, Separation, Anxiety, and Anger. There are many older books that have the basics. And then the newer ones, I'm a big fan of Bessel van der Kolk and his work with trauma. So The Body Keeps the Score. Traumatic Stress is another one of his books, Psychological Trauma. But at any rate, we can list some on the website, so you have a resource guide to go by. But I think it's important, in order to get the treatment that you want, that the person looking for the treatment has a good understanding of what they're looking for.
Yes, and we have so many calls and emails coming into the office daily saying, I've been through 15 therapists and my child's been in an RTC 5 times and nothing is getting better. What are we missing here? And a lot of times it is two things, in my opinion. One is it's a misdiagnosis. No, three things. Misdiagnosis, the wrong medications, which actually, if you're not careful, will actually make a child's behavior 100 times worse. And if a psychiatrist is really not clear about how to treat a child with developmental trauma, they can make things worse. And that's not, I'm not kicking psychiatrists to the curb, but we see it every time we have almost a new entry into our program. And a laundry list of medications, which is not even necessary usually. The other is that we also see that therapists don't understand really about attachment and developmental issues around trauma. That really is significant. Another piece of that, gosh, I just keep adding to my list, is parents really not understanding that they often are the trigger.
Right.
And they need to learn to parent a child who's different. It's not a cookie cutter kind of thing.
No.
Parenting a child with developmental trauma, attachment disorders, there's no playbook.
No,
and
the recipe does not fit all.
No, it has to fit that child specifically. And that's what's so good about our program at IACD, is that we do family therapy. It is family therapy always. Parents are always in our therapy sessions, as well as our treatment parents. So that child is learning in the treatment home. The parents are learning from the treatment parents how to manage their child, how to keep them from being triggered, how to help them not want to be in control all the time. And that is what is going to be successful in therapy with kids. So you really have to have a therapist that can manage all of that at the same time. It's a juggling act.
Right. Reducing anxiety in one child is not necessarily how you would reduce anxiety in a child. And it's the anxiety piece that's running the child. So there are a couple of, there are workshops to attend. There are movies to watch. You had a couple you mentioned, Roxanne, at one time. There's a part 1 and part 2, I think. Remember the name of the movie you mentioned last time?
Oh, Removed. Actually, there's 3 parts of it now. Okay. It is very, if you have not seen Removed, it's on YouTube. And that, it's just a plug for this because I think it's so valuable. I use it in so many of my trainings when I'm working with foster and adoptive parents. Because what it does is it shows the process of being removed, the process of going through the courts, the process of all of this with a child from their perspective, and being separated from a sibling, losing everything. My goodness, how is a child going to learn to trust? Attachment is, the bottom line is trust. Okay. And so it goes through this child's life. It was filmed and written by a family who adopted a child in California, and they just happened to be screenwriters and in the film industry. So they were able to put together these remarkable films. And I suggest to anybody who is working in the field or as a foster adoptive parent, watch those. I've probably seen them 150 times now. And I always see something different in it every time because it's loaded. So don't just watch it once.
No.
They're very amazing. Powerful.
Yeah. Then you have the children from foreign countries who are grieving the loss of their culture. And we don't usually see them in our offices early. Some of them have been adopted later, and it's a challenge to grieve their culture as well. So,
exactly.
Yeah, so there's that component to add to it. So we sometimes joke about the play in the movie Annie. You have a child that superficially charming, that manipulative. Those are not good signs. That movie is classic attachment disorder child from an orphanage. So some people think, oh, my child is so cute and they're so willing to talk to anybody. And, you know, we call it often superficially charming because they would also walk away with anybody. So, what they see as cute behavior is sometimes problematic. Not
Yes.
all, but sometimes it is.
Another really good one it's an older movie, is called Martian Child.
Yeah.
If you haven't seen that one, that one's excellent.
Yeah.
Talks about a child who just doesn't attach to anything but a box.
Mm-hmm.
And he finally learns to trust somebody who cares about him. And it's very good, and it's entertaining as well. So those are some of the resources that we can throw out. We will get some things up on our website as far as a bibliography here very soon. We've been kind of updating that here recently, so we'll have that up there. So anything else, Bev, on that one?
I think that's good for that one. Ready for number 5.
Okay. So how do I explain to other adults what the appropriate actions are when interacting with my child? In other words, having a healthy relationship with your child. I run into this question a lot because the first thing people that say to me is, nobody understands what we go through with this child.
Right.
They don't understand, and they think we're crazy because the child is superficially charming outside of the home. They don't cause any problems. It's yes ma'am, no ma'am. They're helpful. They are considerate. And then they come home and they're a holy terror because they're not required to attach to people on the outside of the house, but they're required to love and attach to a parent figure and siblings. Right. So nobody sees this. It's a big secret, right? So when a child is being overly happy or engaging, they're actually manipulating. And to get people to understand that, because they're so cute and adoring, that's not appropriate, and that you can't just walk up and hug one of these kids and give them gifts and all of these things. It just precipitates more behavior when they get home.
It does. It's a survival strategy that the kids use, you know, out of their anxiety and out of their trauma. It's a survival strategy, but it's not effective in building appropriate, trusting relationships. And so we say, please don't get them attached to things, attach them to mom and dad and family. You know, so when people want to give them gifts and all, it's putting the value on the gift and a relationship with the gift rather than the value on the parents and the family. And so the emphasis needs to switch to the parents and the family. Gifts can come later. Small gifts, we say, that are family oriented. Picture of the family photo book, quilt somebody's made, you know, in the family, maybe one with pictures of the family on. So those kinds of gifts are family related. So we do want the relationship first built with the family, not with a bicycle or things. So, which we often see, the bicycle.
Exactly. Christmas time is terrible, I'm sorry to say, because kids who have been in the system, in the foster care system in this country, are absolutely showered with hundreds of gifts at Christmas time.
Things and things.
And they get nothing during the rest of the year outside of the home. The boundaries, the setting boundaries, I think, with systems like human services, setting boundaries with your friends at church, your neighbors, all of that has to happen, because what they're doing is they're setting the child up to say, well, see, these people are a lot nicer than you are, and so I'm going to punish you because you're not as nice as those other people. So we have a problem. So one of those things that you can tell people that are outside of your home is that you must follow my rules as a parent, and you must set very clear boundaries with this child. And the parent needs to be able to set that to the people that they have the child around. They need to let them know all of what they need to know to be in any kind of contact with that child.
Right, right.
That also includes teachers, Sunday school teachers, neighbors. It's anybody. Seriously.
Anybody. It's anybody.
Anybody.
It's just anybody.
Right.
So may I move on to the next one? There's a lot we have to say about that one.
Sure. Go right ahead.
What is the criteria to get a child or teenager into the Institute for Attachment and Child Development? And part 2, and how do you work with families that struggle to pay for the treatment? So I'm going to have you lead off on that, Roxanne, because you are the one who knows about all of the process of getting into the Institute.
Okay. So usually it's a phone call. We'll get a phone call from a very desperate parent and saying, we want to know more about your program. So that goes through a few of us, whoever, gets that call. And we, talk to them a little bit about what the program is about. And then they decide if they want a packet from us, which gives us all of the information that we need to be able to make some kind of decision if the child is a fit for our program. There is criteria to get in. We cannot take just every child that comes in. Part of that is we are a small nonprofit. We do not have more than 16 beds at a time. However, that's going to go up. That we will have 20 beds here by the end of the year. We're adding another treatment home, but we're small, and there's a reason for that. Is because we have our program looks like more of a family environment, so the child can learn to be in a family. Okay, so I will let Bev talk about that a little bit more. But so the rest of this process is we send out a packet, and it's kind of extensive, and it has history in it and all kinds of information. They send that back to us. We do what is called the RADA, which is an interview. When we get all that back, we do the RADA, which is a interview process with the parent about the child's ability to attach and how they deal with people in relationship, and we score that. And that tells us if they have inhibited or disinhibited attachment. That kind of tells us a little bit more about the child. And it's not something that we diagnose with, but it's something that we use to be able to help us, guide us in our therapy if that child does come into the program. The parents also, we do what's called the MCMI, which is a inventory, a personality inventory, because again, this is family therapy. This is a whole system. It's not just about the child. And we know if a parent has some mental health issues or anything like a lot of anxiety or narcissism or deep depression, any of those kinds of things, we kind of need to know this, and because that helps us in our treatment to help them deal with their child because of their own issues. Okay, and many times we'll say, if we take that child in the program, we also want the parents to be doing some therapy on their own outside of what we do in family therapy in their own hometown. So we get all of that back, and I look at that and talk with a couple of other people in the program, and we make a decision whether this child can come into this program. One of the criteria is we will not take a child that's violent. We have to keep the children in our program who've been traumatized safe. We don't want any further traumatization. We have to keep our treatment parents safe. We have to keep the dog and the cat safe in the house. So that safety is number one here. Okay. That's the first thing I look at. We will not take a child who's highly acting out on suicidal ideation. That is not fair to the family to have to always be dealing with a child who's wanting to hurt themselves constantly. So we also sometimes take a look at the parents. We recently had a situation where the parents were more difficult to work with than the child was, because they become very, very enmeshed, and they want to run the program for the child, and those are things that we kind of get an alert to. I also will do an individual, before a child comes in, I take time to call the parents and spend about an hour on the phone with them, asking them all kinds of questions, and I want more history. I dig deeper than what's even in the paperwork. So we screen people pretty thoroughly. And so that's kind of the process up front. Fingerprinting, there's just all kinds of things that go on here, so that we make sure that, and right now, we will not let a child into our program unless they've been quarantined for 14 days.
And clean and sober. If they're vaping,
right.
If they're drinking,
yes. We have that also in our paperwork, that a child cannot come in who's actively in an addiction or even smoking.
Right. So what it is that they may need just a different level of care.
Yes.
And children that we have applications on need a higher level of care. So our level of care is very specific. It's very family oriented. And some of the kids who need a higher level of care can get that higher level and then reapply. So it's not like they can never come back. They can get the higher level of care, and then the team can take a look at the application again.
Yes, I'm always open to looking at a child's application after, there's been some change in their behavior and it's been stable for a while.
So it's important to have that personality inventory of the parents too, because it will show in what areas the therapist can best support the parent to meet the parent's needs. If they're exhausted, which most of them are, most of the moms are exhausted, how to help them with that. If there's depression, how to help with the depression. And to remember, I'll say it again and again, attachment is a two-way street. If the parent has only so much energy to go so far in attaching to their child, and they're exhausted from being themselves triggered all the time and worn out, then the child will intuit. They will sense that the parent can't go any further, that the parent is not going further emotionally, and then the child will stop. So it is a two-way street. The parent needs support to recognize, where they are in their own process and how able they are at this point with their child to form a bond that can develop further. We say we're the beginning of teaching about bonding and working with the developmental trauma. We're not the end. We are the beginning. We're the start and the jump start for the families to go forward and develop their own family system in a healthy way. So we're not the end. We're the beginning.
And there's a couple other things that I wanted to add with that. When we look at a child coming into our program, we also look at what homes we have available, although they might have to go on a waiting list, and which home, because they're all a little bit different. Like we have one home that we just put all the big boys in, okay? All the big boys go into that home. And we have some that are co-ed, and we have some where kids are a little bit younger. So we're very careful about where we place children also. So if we don't have an opening, but we think a child will fit in our program, they may have to be on a waiting list for a little while until we have an opening. Like I said, we don't have that many beds. And as a child comes into the program, they sit with our psychiatrist and the parents in person. We do an intake takes about an hour and a half. Most of that time is the psychiatrist talking to the parents. So they are reporting. We find out more stuff that way that we didn't even see in the paperwork or when I was talking to them. Sometimes we're a little surprised with something that comes out of that. That face-to-face.
The children, the parents we have to count on, because as we say, the children are not necessarily accurate historians.
Right, exactly. Good reporters. So we do that, and then the therapist that's been assigned, and that also, I look at that too. That's part of the fit. That because every one of our therapists is a little different, and their backgrounds are just a little different. They're all very, very well trained in attachment and family systems and trauma.
And we have 4 or 5 now. We have 4 or 5 therapists.
We have 5.
5. So Roxanne has to take a close look at that and then approach the therapist to see if the therapist thinks that it's a fit for the therapist caseload as well. So there'll be times like when she'll bring me a case and I'll go, I don't believe that's going to be a fit for me. So then she has to assess all of that.
Yeah, it's a puzzle. So I put the puzzle pieces together, and with help, feedback from other people in the program. I don't do this randomly by myself. But there are a lot of eyes on these applications. And so after the intake, the therapist takes the parents and the child, and we do our treatment plan right then and there from what we know up front. We also change those treatment plans a little bit as time goes on because, more things come out, things are resolved, it just changes through therapy. Yeah.
Sometimes they meet the goals.
Right. So that's pretty much the process of this. And so anybody who's out there listening to this Fireside chat is interested in or knows a child who may be a good fit for our program, you can go to our website and get that information, and we can contact us and we can talk. So
we can talk. So Roxanne, did you see on there, it looked like Carly maybe had a question from the outside?
Sorry.
I don't know.
I did not, because I had it covered up. Sorry.
Let's see if Carly will let us see that.
With regards to those viewing your child as being different than they are at home, what can you do when no one believes you? How can you help others understand that you are not just being mean and making things up to restrict your child? Are there movies or articles they can read? Okay. Bev, you want to answer that? And I'll add in.
So yes, first of all, I would support anyone to connect with the parents. RAD Advocates is a good group to connect with to get more language in how you deal with others when they think you're just being mean. The movies that Roxanne mentioned, you could always say, suggest to the people to watch those. And I think that it's almost inevitable that people are going to think you're the bad guy. Okay, so I think it's important to get your own help in order to develop a thicker skin for that, because you are going to be targeted as the, well, we say it's the nurturing enemy, but you will be targeted, unfortunately. So you can't educate everybody in the world. It's not possible. Oftentimes we say, well, we're parenting to each child's needs. This child has these needs and we're parenting to these needs. This child has these needs. But to be on the defensive is a horrible spot to be. And I remember years ago, had a little girl who liked to run backwards and crash her head into the glass. So we put a little helmet on her, and her mom took her out, and she said, people are asking why she's wearing a helmet. And I said, well, you have her tell them. The little girl was 9. I said, have her tell them why she has a helmet on. So sometimes you can use that strategy, and sometimes you can't. So it's situation by situation. But unfortunately, I don't know when I've seen a parent not labeled as like the bad guy.
Yes, it happens all the time. And so I would also suggest that you look in your community to see what there should be some kind of support groups out there for adoptive or foster parents. I know here, I'm on the board for Colorado State Foster Parents Association, and we have a private chat Facebook room that only certified foster parents can be in. And that is been very beneficial. I'm not kidding you. When we put that up, within a week, we had 100 people on that because there's such a need. And I hear these questions constantly. The only people who monitor that in our situation are the board. And so we're the only ones. We don't let caseworkers in that. So if you are not in the Denver metro area and you're watching this, which I'm suspecting there'll be a lot of people that are not here, you might want to start something like that with a therapist or an organization and say, hey, can we get a private chat? And people help each other with that. It's very, very powerful to have somebody who really understands you and knows what you're going through.
Yeah, the chats are interesting to have a balance in the chat group too, because you don't want a chat group that just always talks about the negative. You want a chat group that problem solves together, puts their heads together and gets creative and say, okay, well, we tried this and that worked. We tried that and that didn't work. So you want more of a problem solving group. Yes,
and that's what this one is. And we have some parameters, some rules about this group, that we don't sit and bash people. We don't, and we are helpful to each other. There are some real parameters for that keeps it healthy. Groups can become unhealthy and they just become, complaining sessions, and nobody needs that. So, so it looks like we are, I want to go back to about the struggle to pay for treatment. Okay. What we know is that our program is significantly less than an RTC, and that we also provide a whole lot more services and therapy than most RTCs. But it still is not the most inexpensive thing in the world, because we have to have room and board. We have to pay for our therapists and all of that, as you should understand that it takes money to operate. So a lot of times we have, actually the majority of our people who come into this program are not Colorado people, because our Colorado Medicaid will not pay for it. And if a lot of our people in Colorado are paying out of pocket. So if you can't pay out of pocket and you are out of state, please go to your insurance and see if we can get a single case agreement. I can tell you most of the major insurance companies will not do it either. It's usually Medicaid or some type of adoption subsidy type of money. Like California is really good about that. Oklahoma. There are some states that are really, they send us a lot of kids, and their Medicaid just pays for it. It's not tough. I can tell you the funding piece is a struggle and sometimes a barrier to getting your kid into our program. And it's very unfortunate that there's not funding out there for this type of mental health and family work. So that's about the best answer I can give you on that. If you have more questions about that, please call into the office and talk with somebody by the name of Paige, who is our director, and she will be able to walk you through that type of thing for funding. So it looks like we're out of time. Yeah. And I can't believe we got through all of those questions.
Well, thank our audience.
Yes, I know. But what I'm going to suggest, we want to continue doing these fireside chats. Please, please, please send in questions. We will put together another fireside chat as soon as we get enough questions, five, 6 questions.
We
And
have
we will
some. We already
this-
have some that came in and we couldn't get to today.
Right. We have some to build on. So please send in your questions. We would love to continue doing this series. And thank you for watching and attending. And I hope that you've gained something out of this hour. And please go to our website, which is instituteforattachment.org. And you will have a lot of information there. There's lots of articles, and if you
Parent tips, we have parent tips.
Parent tips. We've got a lot of things going on. So thank you very much, and we appreciate you attending.
Thank you. And the Institute's number, I'm going to give it out, is 303-674-1910. The Institute for Attachment and Child Development, if you want to call in, is 303-674-1910. Thanks, everybody. Bye.